If you don't fix the gut, you're never going to be able to detox properly, and your chances of getting this organism out of the body is going to go down drastically.
Myriah, welcome to the show.
Thank you so much for having me. It's an honor to be here.
I really appreciated your approach to Lyme disease and treating these chronic infections because you really focus on herbals. And there's a few things in particular that I really want to equip the audience with. You presented at the 2024 ILADS conference, which was great, by the way. And you talk a lot about many things, but two things I really want to hit today because I think they have a lot of relevancy to our audience. One, the tie-in to how these bugs can really screw up, for lack of a more medical term, gut function, knowing so many people in our audience are struggling with something gut-related. And then two, tied in along with that, is the chronic inflammation that these bugs cause. And that's going to hit the gut, but also the brain and also the joints, also the skin, pretty much everything. So I'm really excited to have you share more of the research you've been doing, some of the products you developed, and just everything that we can equip people with who may have done all of the gut stuff that we talk about, seen some improvement, but I had this growing suspicion that for the people in which they've done many of those interventions, low FODMAP, maybe Candida diet, probiotics, a reset with herbal antimicrobials, elemental dieting, immunoglobulins, whatever it is, and they've seen some improvement, but they're still saying, I have to work really hard to kind of be average. And I have these oscillations between not doing so great and going back to average. I think for a subset of these people, they've got some sort of chronic low-level infection. Oftentimes, maybe it's Lyme. So anyway, with a lot of preamble there, this is what I'm really excited to kind of unpack.
Yeah. So let me ask you for a clarification. Are we talking patients that are still infected, or are we talking patients that now have gone through treatment and maybe their infections are resolved and we're trying to clean up the gut after the fact? I just want to make sure I answer.
Great question. We probably have some of both in the audience, but I'm assuming since we've been newer to discussing this topic of vector-borne infections, which is the more contemporary way of saying Lyme, people who are earlier on in their journey.
Yeah. So, I think the important thing to understand, and this is just going to kind of come out the way that it comes out, it always comes out in a different order. But, for me, these stealth infections that become chronic, they become chronic because they manipulate our immune system to basically work for them instead of working for us. And when they manipulate the immune system, they make the body hospitable. And one of the main places where this occurs is in the gut. So these organisms exploit inflammatory cytokines, which, pretty much now post-COVID, everyone knows what that word means, right? It's a fancy word for chemical inflammation. And basically this inflammation breaks down the tight junctions in the gut. It does a lot of things, but if we're just going to focus on the gut, it breaks down the tight junctions and it allows for increased intestinal permeability. And so when this happens, we start to leak all sorts of things through the gut into systemic circulation. So we bring in toxins that are supposed to be kept out of the body, other pathogenic organisms. We can have partially digested food that now turns into basically like an antigen in the body, and it further elicits an immune response against these undigested food particles that can lead to various food sensitivities, which can then lead to other immune issues and autoimmune reactions and more inflammation. And it's just this big slippery slope. And so when it comes to killing these organisms in the body, when you kill an organism, it releases its own toxins. And with the spirochetes, which are the type of bacteria that Lyme is, it releases this LPS, or this endotoxin, that further fuels the inflammatory cytokine cascade and can actually cause what's called the herxheimer reaction, which kind of makes everything worse. So it's hard to focus on healing the gut when you're still infected, but you can't treat the infection if you're not focusing on healing the gut too.
Sure. Which makes me feel good about the fact that I've dedicated so much of my time and research and focus to the gut, because I don't think anyone in any silo, Sears, mold, thyroid, adrenal, cognition, everyone harps on the importance of the gut. So for our audience, we want to make sure we have a solid gut foundation. But like you're saying, and I think about the Erdman paper that was really pivotal in showing some very high percentage, I think it was maybe 50%, maybe a little over, of people with chronic vector-borne infections also had chronic gastrointestinal symptoms, I think for the very reason you're describing. And you've talked about a few ways to modulate inflammation, and maybe taking a step back, how is it that the microbes benefit from skewing inflammation? Are they suppressing is it the Th2 that they suppress because they suppress the Th1 because that's the arm of the immune system that is going to attack them, but it leads to sort of runaway Th2? Or, maybe for people who are not quite sure, because they're saying, well, doesn't inflammation kill the infection? Because we've talked about on the podcast in the past that if your immune cells are like little police officers, their guns would shoot inflammation as their main instrument. So how is it that you can be inflamed but not be efficacious at killing a bug?
Right. So in an acute situation, in an acute infection, yes, it is the Th1 branch of the immune system that would come in. You would increase some of these inflammatory cytokines, which would actually be good. And they would help to, initiate the killing of these organisms, and recruit in different immune cells for repair and whatnot. But what happens is when we have a chronic elevation of some of these inflammatory cytokines like interleukin 1 beta, tumor necrosis factor alpha, IL-8, IL-6, and something called galactin 3, it shifts it into more of like it's almost like an overdrive, right? And then we get into this Th2 dominance, and the body can almost start attacking itself. I think a good analogy is like, if you think of a sniper where it can put its little red dot right on the target and it safely blows up that target without harming anything else around it, that's how I think of the normal functioning immune system, like immune competence. When we have immunoincompetence, right, or we're in this other sort of like inflammatory bomb state, which is what happens with these chronic stealth infections, it's like the plane flying over top, right? And they're told their target is underneath and they release the bomb. But by the time they release the bomb, has the target moved? Has it hid elsewhere? But regardless, that bomb is going to blow up the terrain in the process. And so it's that altering of the terrain, the inflammation, the dysfunctioning in like the terrain itself, as well as the immune cells that actually like creates this hospitable environment, because most of the patient's symptoms are a result of this inflammation. So the inflammation not only breaks the immune system, but it literally allows for the breakdown of the collagen, of the extracellular matrix, of literally all of the nutrients that these organisms need to not only survive, but thrive inside of our body. And then it causes basically all of the massive, pain, weakness, destruction, nerve inflammation, as well as a lot of the neuropsychiatric symptoms that are seen. So inflammation to me is like the number one enemy. And the number one goal is to restore proper immune function, which you can't do without dealing with the inflammation.
And by the way, if this has been helpful, please comment and subscribe. This really does help us reach more people who are trying to improve their health. So it is quite deeply appreciated. I want to credit you for making me aware of galactin 3 in terms of its relevancy here, and how modified citrus pectin can help reduce galactin 3. I'd love for you to speak more about that. One of the things, just really quick, that I found interesting about galactin 3 and the fact that modified citrus pectin can lower it. So our audience has probably heard about citrus pectin, which is different than modified citrus pectin. Citrus pectin's quite helpful for constipation, or psyllium, per a recent meta-analysis, the two most effective fibers for constipation. But when it's modified citrus pectin, it actually gets absorbed into the blood, and it can bind toxins in the blood, which I think has much more relevancy, not to diminish the importance of sort of in the GI tract, something like psyllium or pectin sequestering bile and helping to poop out toxins via the feces. Good, right? Fine. But I think, like you're intonating, a lot of the toxins, whether it be LPS or inflammation, are in the bloodstream. And this is where the modification of the pectin allows it to get absorbed into the bloodstream and start pulling toxins out and reducing inflammation. At least that's my understanding. But I'd love for you to sort of unpack this a little more for people, because I do think there's something here that I'm assuming can help with some of the herxheimer's reaction, amongst other things.
Yeah, absolutely. So, taking a step back and looking at galactin 3 in an acute situation, just like a lot of the other inflammatory cytokines, like galactin 3 is a very useful, helpful substance. It's kind of like when the fire alarm goes off, and it basically tells everyone where to go and how to get there and how to put the fire out, right? The fire being the infection, the injury, whatever. But once it has been chronically elevated, again, it's like that overproduction and that, overstaying your welcome of all of these immune cells. And it can lead to cytokine cascades. It can lead to mast cell activation. It can lead to fibrosis. It can lead to cancer. It can lead to all of these different things. So then you're absolutely right. So typical citrus pectin would just stay in the digestive tract. And yes, it's great for trapping toxins that have been expelled into the digestive tract so you can poop them out. It's been modified and goes through an esterification process. And this is actually, I will disclose, like, all modified citrus pectins are not created equal. There's one particular brand that over 8,000 studies have been done on with galactin 3. So, I just want to make it clear they've not all been studied. And when I'm talking about it, I'm talking about a specific one called Pectisol.
No, yeah, I thank you for saying that, because that's one of the things I noticed and I came across. And actually, the skeptic in me said, well, how different are these? So I bought 3 formulas, and at least visually and with how they mix, there's a difference between Pectisol and non-Pectisol modified citrus pectin.
Right. And so, I don't know exactly what the patented, I know the specs, but I have never sat down and looked at Pectisol versus the others. I just know that I really try to stay evidence-based. And so I'm going to look to the one that has the studies behind it. That's personally, I have my own version of it that I use with my patients. And also at this point, I've been using it for, gosh, at least 6 years. And it's an integral part of my treatment protocol. So I want to make sure that I'm answering the questions that you asked. So basically, it shuts down the inflammatory cytokine cascade. It increases natural killer cells. It helps to bind LPS and endotoxins as well as mycotoxins. It actually breaks down the backbone or the scaffolding, like the galactin 3 piece of the biofilm, which is the fort-like structure that these organisms kind of hide behind. And in that structure, you can also have heavy metals and other toxins. And it's actually able to bind a lot of these heavy metals. It also encourages healthy collagen formation and can pull fibrotic plaque out of our tissues made from collagen. So, it hits all of my treatment bases. Now, I'm not for a moment, and I don't want anyone listening to think that I'm suggesting that this product is going to like cure your Lyme disease. You know what I mean? In fact, I instruct people to run from people who use the word cure, but it's, to me, one of the foundations because it does so many things. It's one of my foundational treatment products, but you have to know how to incorporate it into, a holistic, individualized plan.
How I came across modified citrus pectin initially, I think the name of the study was Prove It, where they were essentially trying to disprove that heavy metal chelation did anything. And they actually inadvertently proved that it was efficacious. And they used modified citrus pectin. And that really got me to perk up and say, well, at least for heavy metals, it would make complete sense. And I didn't realize, but again, it makes so much sense that it would also help with the biofilms. So now I'm getting an even better understanding why you're so keen on the use of modified citrus pectin. When do you think it's a good time to incorporate this? Is this something early on all the way through? Do you have a certain phase of treatment where you think you want to be using MCP?
So it depends on the person. It depends on I would say kind of on how messed up their gut is, right? Number one. I typically do use it with almost every single patient. And sometimes I will start it before I actually start using antimicrobials. Sometimes, if the patient is very, very sensitive and I'm more worried about it breaking down biofilms and almost like releasing active bacteria before I have antimicrobials in place, I might not start it right away. So it really depends on the individual, but it is something that I typically use throughout their whole entire treatment protocol. It's actually very helpful at healing the gut. Like it has an active role, as you can imagine now, at helping to decrease inflammation at the tight junctions and help to deal with increased intestinal permeability.
And even though it's modified to be absorbed, I'm assuming it still has some prebiotic function, and therefore people will probably have some gas, bloating, flatulence, burping for the first week, maybe two, that should slowly subside. Is this something people should be sort of on the lookout for?
It happens in a small subset of my patients. It definitely happens, but I would say, it's probably 10 to 15%. It's not a big number. And for those patients, I will go back. So typically I'm using, a scoop of it, which is roughly about 5 grams. And so I might back them up and say, okay, start with 1 gram, or start with half a gram. Start as low as you need to start so that you're not feeling distress and then ramp it up. And my dose, I'm looking at the 5 grams 3 times a day. That's really the dose that I'm looking for. Now, with kids, I use about half of that. And I will use it. I've used it in kids as young as, 18 months old,
And sorry, for adults, you said you're trying to hit 5 grams per day?
3 times a day.
Five, 3 times. Okay. And that's what I'm blanking on his name. I think he's based in Israel. Yeah, he's done a lot of the
Dr.
research
Isaac
where,
Elias.
yeah, yeah, yeah. Okay. And he recommends 15 grams per day. So that makes sense. 3x. One of the things that comes up too, of so many things, but is histamine intolerance. Obviously, when there's LPS, leaky gut, reactivity, chronic inflammation, you're going to see this overzealous immune system. One of the things that's offered up is various antihistamines, some natural, some pharmaceutical. Do you find with the histamine picture, at least the symptoms maybe, does the modified citrus pectin have any effect there?
So I've had a lot of practitioners ask me, and I've had a lot of patients who are well versed on histamine and histamine containing foods ask me about this. My experience is that it's not an issue, and I can explain why in a
Oh, and
moment.
I'm sorry, not to cut you off, but I should maybe set a little bit of context because citrus is high histamine. And so some people just totally based upon seeing citrus
Yep.
will say, oh, I'm not going to do it because
And
I have
that's
histamine
yeah,
issues.
that's
Yeah.
exactly what
So
I mean.
just for that context. Yep.
Yes. So, yes, the concern is often there, and I use it anyways. So I still recommend, every other aspect of a low histamine diet. And then, I do things to help to stabilize the mast cell. I use various enzymes, right, that help to deal with histamine. Maybe the easiest way to answer your question is to try to use a patient as an example. So, and I'll try to make it a short story. I had a patient who came in, he had head to toe unexplained urticaria or hives for 7 years. He was on literally 4 different antihistamines. He still was getting at least 1,000 hives a day. No joke. There was no one could help him. Long story short, he tested positive for several tick-borne diseases. I did my normal thing where I go through, I look at what micronutrients he's deficient in from an intracellular, so an inside of the cell perspective. I eliminated all of his IgG, IgA, IgE food sensitivities. We did some things to try to heal the gut. I put him on some mast cell stabilizers. I put him on some proteolytic enzymes and treated him for his tick-borne disease and used the modified citrus pectin. He's taken a very long time to recover. But he is now to the point where he only takes montelukast once a day. He has not had hives in about 6 months at all, from thousands of hives a day to no more hives. And, um, but it's like, but we used this. So I use the story with everyone who asks this question, because like I'm like, here is someone that visibly had uncontrolled histamine response. And we used something that is a histamine containing food, you know what I mean? And he still healed, he still got better. We're at the point where we're weaning him off his entire protocol, and switching him into maintenance. But also, I should say, it's taken 3 years. None of this is a short, quick fix. But for someone who had it for 7 years, it completely uncontrollable, and then to be able to resolve it in 3 years, and be able to wean off that protocol, is huge.
And that's, I think, an important reference point regarding time. Because these bacteria are really slow growing, I think people need to set their expectation that it's not going to be as quick as many of the things in GI. SIBO, Candida, a lot of where I've learned so much clinically, you can make a big dent in 1 to 3 months. I would argue the majority.
I would agree.
These organisms don't follow that same trajectory. You may see symptomatic improvement in 1 to 3 months, which is amazing, and people are feeling better and their life is easier. Great. But the thing I'm really learning is if you pull back too soon on the treatment program, the incidence of relapse is going to be pretty high, which also makes me wonder if maybe this is why some of the, in air quotes, your chronic SIBO or chronic Candida cases are really the deepest etiology is a vector-borne infection, because a lot of time people aren't re-quantifying with the SIBO retest or a Candida retest. They're just going based upon the fact that they have symptoms recurring. And then they're saying, well, I'm blaming the thing that I know of. So a SIBO breath test. But this is another challenge for the audience, maybe, is to expand your paradigm a little bit, because in my observation, and no one knows for sure, it's just my intuition, but if, again, someone's doing all of the GI stuff and they're continually regressing, and you're sure there's not some sort of anatomical issue, right? There's not a prior surgery, and there's an inflection point with scar tissue that's causing a backup. So if those things have been adequately ruled out, then I would be thinking about this, again, like you're intonating, that they can be a longer course of treatment and time to resolution, not meaning that you have to wait 2 years until you see improvement. That's also, I feel, really important to underscore. You should be seeing some improvement within the first few months, but you just don't want to stop treatment too early, because these bacteria can go into a non-growing phase, and as you said earlier, into biofilms, and they can hide and they can come back out at a later time if you're not really thorough with the scope and the course of your treatment.
Right. So I totally agree with you. My baseline or my expectation for a patient is I will see a 25% improvement within the first 90 days of getting on their full treatment protocol. That's what I'm looking for. That's my lowest sort of like acceptance. And I typically see that. And now that might not be 3 months from like the day you became my patient, but that's 3 months from when you got on, because there's definitely a weaning or an onboarding process here, right? Of figuring out what's wrong with the patient and strategically getting them onto their plan. For me, it usually takes about 4 months. So 4 months from the first time you see me, I'm expecting a 25% improvement. And that doesn't mean every single symptom is going to decrease by 25%. I have a lot of patients, that they will lose several symptoms in that period, and other symptoms won't budge, and then other symptoms come down by 50%, some only by 10. And it's something that like we do, I do a subjective thing with my patients every single time they come in where I have them rate the severity and the frequency of their symptoms because they live in that body 24/7. And if they feel like crap, they feel like crap. And so a lot of times patients will say, "Well, I don't feel any different." And I'll say, "Okay, that pain in your right big toe, how is that?" And it's like, "Oh, that's gone." "Well, what about that weird vibrating thing that you felt in the back of your head?" And they're like, "Oh, that's gone. I forgot I even had that." And it's like, well, yeah. And that's why we go through, and we evaluate all of that so that we can make sure that they are getting better. Because a lot of the progress you can't measure in labs. A lot of
Agreed. And
it
this is
is
why,
out.
yeah, this is why we've been using the MSID score
Yeah.
periodically because people will forget the symptoms that they had, which is great. I think the faster you can forget about the symptoms you had, on the one hand, the better. On the other, to your point, if you're focusing from 10 symptoms to now 5 symptoms,
Mhm.
and you're not accounting for the fact that 5 have improved, you could conclude incorrectly, well, I'm not really feeling any better. The other thing too here that I'm curious your thoughts on is the herxheimers. I think of this patient I saw a few weeks ago, just diagnosed with Bartonella, which is known chiefly to cause some sort of pain. And she had this neuropathic pain, and she had done some herbal treatment before her labs came in. We had a follow up maybe 3 weeks later. So in that interim, she self treated with various herbals, and she said, "I just had exacerbations of my nerve pain the whole time." And for some people, the herx does seem to be somewhat protracted. How I'm trying to think about this now is really focusing on antioxidants, detoxification, and other things to quell inflammation if you're seeing that herx. But let's open up the can of worms of herxheimers. How often do you see it? Are there any pearls that you find particularly helpful for the herx?
Sure. So, I mean, really, if you look physiologically at what the Herxheimer reaction is, it's an increase in the inflammatory cytokines and usually a acidification of the body, right? And these toxins are building up more quickly than the body can excrete them. So, I kind of look at dealing with a Herx in four parts. So, number one, and I'm going to have to like come back to this after, but number one, like we need to fix detoxification. And in my opinion, before you even have any business trying to kill any of these organisms, you need to make sure that the routes of detoxification are functioning properly. And in addition, it's the routes of elimination as well. So we can't just detox. We don't want to focus on pulling things out of cells where they've been sequestered to not harm our vital organs, right? We need to make sure that we're eliminating. So we're pooping, we're peeing, we're breathing, we're off gassing toxins, we're sweating, all of these different ways to get toxins out. Then we work on phase one, phase two of the liver and pulling, cellular drainage, lymphatics, things like that. But it's like you have to start sort of at the bottom of the funnel and work your way up. There's various nutrients that are needed to support detoxification. There's methylation, like all of these things, in my opinion, is like the foundational work that needs to be done before you even start trying to dislodge any organism from the body. So we have to make and the gut is almost like the number one thing involved in detoxification because if you're leaking toxins back in, then you're not detoxing, right? So, gut and detox, number one, and that's part of the background work. I would say next, we have to focus on binding these endotoxins, right? So, we can use various binders. Obviously, I love the Pactisol, but I also like chlorella. And then also, my good friend Jill Krista talks a lot about using food as binders. So when we use foods like ground chia seed, ground flax seed, that are gelatinous and that can bind onto these things, we get the benefit of them being food, but also they help to pull them out of the body as well. So we need binders. We also need antioxidants, polyphenols, bioflavonoids, things to actually help to offset like the oxidative stress that ultimately is caused by these things that cause cell damage. And we have to work on alkalinizing the body, right? So to get us out of that acidic environment, and we need to use anti-inflammatories. So those are kind of like the pillars of dealing with a herx, as far as I'm concerned. I love chlorella because chlorella is very alkalinizing, but it's also a weak binder. And you might catch on that I'm saying weak binders. I don't use a lot of strong binders. I don't recommend the use of activated charcoal with my patients unless someone is undergoing something very, very severe and very, very acute, because activated charcoal acts like a super sponge and it's going to bind everything. It binds nutrients, it over binds, and it's actually not very good at excreting it out of the body. So it pulls things out very, very quickly, but a lot of times you'll actually get the reabsorption. So my favorite things are things that are effective at binding, but they're not going to bind nutrients, because a lot of what I'm doing is long term, right? So I'm not comfortable with patients staying on activated charcoal for weeks and weeks and weeks. I personally just don't think it's a good idea, and I think there's better ways to go about it. So again, gut health and detox, using binders, using antioxidants, using anti-inflammatories, and using things to alkalinize the body. Those are sort of the 5 steps that you want to pay attention to.
And can you lay out the detox work? It sounds like there's maybe 2 levels of detox you go through before you then go to antimicrobials, but for the people who are struggling and trying to quarterback this themselves, how would you recommend they sort of sequence?
Okay, so there's a couple analogies, right? We could use the bucket analogy or we could use the overflowing sink analogy. Um, we'll do the bucket. So if we look at all of the different drops into the bucket, and let's say like the bucket overflowing is like this really, inflammatory state where you're not detoxing toxins or spilling back in, you want to look at all of our toxic load. So, we breathe in toxins, we eat toxins, we slather toxins all over our bodies and clean with toxins and all of that stuff from our external environment. But then we also, just from like cellular respiration and exercising and all of these other things, we generate toxins. And then all of these bugs inside of us put their waste into our body and their toxins, right? And then we have, when we're killing the bugs, they're releasing toxins. So we have all of this various toxic mess coming into our body. And so the number one rule for me is to decrease your exposure, right? So decrease as many environmental toxins from coming into your body as possible. And Michael, you and I could talk about this for way more time, than we have for today. So I'll leave it at that. Then we want to make sure next, I would say, look at the routes of elimination. So are you pooping every single day? If you're not, you're constipated. Are you drinking enough water so that you're having enough urine output every day? Are you doing deep breathing, or are you stuck in this shallow breathing? And are you doing things to help your body to sweat? So I would say from an elimination standpoint, those are my basic eliminations that I would evaluate with a patient. Then we want to get into, okay, even if we just looked at phase 1 and phase 2 of liver detoxification, there's a whole slew of micronutrients. So vitamins, minerals, some are antioxidants, etc., that our body needs to be able to run those 2 phases. And it's not just making sure you have everything to run both phases, it's trying to coordinate the 2 phases. So if phase 1 is working more quickly than phase 2, you can actually have a buildup of these toxic intermediates. And those toxic intermediates are more damaging to the cells and cause more oxidative stress than the original toxin did. So we want to coordinate phase 1 and phase 2. So think about 2 escalators that are running at the same speed. Everything would be slow and steady and out of the body. If the first escalator was running faster, you would have like this buildup while you're waiting to get on the second escalator. And to me, that kind of signifies like, okay, there's the toxins building and now wreaking havoc. So micronutrients are necessary, making sure that you have what you need to methylate properly in the body. There's all of these other, I guess, micronutrient dependent processes in the body. And then we have like our lymphatic system, right? So there are things that we can do to increase circulation, increase lymphatic circulation to actually get the toxins like from the cell through the system and then either, into the kidneys or into the colon to be excreted from the body.
Homeopathics and brushing are two of the interventions I've seen for lymphatic detox that are fairly well recommended across various providers. Agree?
Sure, they're helpful. So some of the things that I like is doing rebounding because it's so gentle on the body and gentle on the joints. So I think it's a good thing that patients can do. You can do the health bounce on a regular floor, and that helps to stimulate the lymphatics. Um, Obviously, you can do lymphatic drainage massage, which I love. They also have kind of like those pressurized sequential like booties you can put on that work really well. But I'm a big fan of like the vibration and the like the rebounding to actually help to move
Sure.
lymphatics too, and then of massage.
And I've heard people comment that they just find the rebounder to be fun. And from the few
Yeah,
times I've jumped on a trampoline, not that I'm doing it for lymphatic purposes, it is, I can see myself being fairly easily convinced to jump on a trampoline for what do you need, a minute, maybe
yeah,
three
not
to
long.
get that?
And I
And they're
think
small, right? They're not expensive. You can
yeah,
put
right.
them in your like garage or something.
Yep. And a lot of them have like handlebars so you can hold it. You know what I mean? If you're really
Yeah,
incapacitated.
sure.
And it's the great thing is like it's hard to get on one of those things and not like laugh and smile.
Not
You know
smile.
what
Yeah,
I mean?
totally,
So,
totally.
which is
And for some people,
important.
they need a win. Yeah, if you're going totally, if you're going through a tumultuous road, you're having detox issues, herxheimer's reactions, you're not feeling well, any little sliver of a smile, joy can be a big win for some people. Totally.
Absolutely.
Okay. With the bugs in particular, the way I've been thinking about this, and it seems over maybe the past few years as the testing's gotten better, we used to think it was mostly Borrelia, and this is probably at least my reading of the tea leaves here, because the testing for Bartonella and Babesia weren't very good. But over the past few, maybe 3 to 5 years, I think anyway, testing there has gotten a lot better, and we're better appreciating these other organisms like Bartonella and Babesia and getting, I think, a better complete picture of it's not just the Borrelia, the Lyme bacteria, but it could be a totally different organism, not a bacteria, a protozoa. And while there's a lot of overlap with the herbal killers, antimicrobials, there does seem to be some distinct differences. And certainly for antibiotics, the antibiotics hit the bacteria, but they don't hit the protozoa. And this is where you see things like the antimalarial drugs, tefenaquine, atovaquone, being used with sort of their herbal counterparts, Cryptolepis, Artemisia, Sida, Acornia or Alcornia. But do you skew at all based upon these organisms and sort of favoring one? I know your broader, more holistic approach is going to address the inflammation, the immune system, the detox, and that's going to help everything. And that's one of the points I'm so glad you made during your ILADS talk, which is we can't just hammer on the antimicrobial therapy devoid of these other things. But as you do think about maybe being targeted, or maybe you don't, with protozoa on the one side versus bacteria on the other. So for our audience, that's Babesia on the one side, which is probably more common than the other two, Borrelia and Bartonella, which are both bacteria. But how do you think about, if at all, the distinction between the herbals and the microbials for these two?
Okay. So you just brought up so many things that I want to talk about. Can we go
Great.
back to testing in a minute? Because I
Yeah,
want to answer your question, but I think it's super important to go back and talk about testing really quick at
sure.
the end. Okay.
Yeah.
So to try to answer your question, I mean, the wonderful thing about a lot of these herbals is their dynamic actions. So like for example, you brought up cryptolepis. So cryptolepis is anti-spirochetal, right? So that's the actual type of bacteria that Lyme disease is caused by. And it doesn't matter what species, which we need to talk about when we talk about testing, like what species of Borrelia, which is the type of spirochete, it's effective against all of them. But additionally, it's effective against malaria. And this is what this herb was originally used for and still is to this day, is used in places like Ghana to treat malaria, and it's very, very effective. So Babesia is kind of like the cousin to malaria. It's a parasite. And so not only is Cryptolepis anti-spirochetal, antibacterial, anti-parasitic, also antiplasmodial, right? It's got all of these antimicrobial properties, but it's also anti-inflammatory as well. So a lot of these herbs have these dual actions and these side benefits, instead of having side effects. So Sweet Annie is pretty much the same. So that's Artemisia annua. And yeah, so I think that answers your last question. But going back and talking about testing real quick, it's so important to really clarify, are we talking about testing through conventional labs, or are we talking about testing with a specialty lab? Because, can I mention mainstream labs, or am I not supposed to?
Yeah, of course,
Okay.
please.
So, like, if we're looking at Quest or LabCorp or something like that, which is the typical lab that your doctor is going to use, like, say that we're just talking about Lyme disease. So, first of all, oh my gosh, it could go on and on about the testing. But basically, the one thing to remember is that the test is looking for Borrelia burgdorferi. So, it's looking at one species of Borrelia that causes Lyme disease. There's about 20. So, that's like me saying, here, I'm going to hand you a box that has 20 different colors of crayons, and I want you to pull out a crayon. And you pull out a green crayon, and I say, cool. I'm going to come over and I'm going to tell you if you're holding a crayon using my test, but my test can only see a red crayon. So I'm going to come up to you. I'm going to look at your green crayon. I'm going to say, it's not a red crayon. Therefore, you don't have a crayon. And you're going to tell me I'm crazy because you're clearly holding one. That's what getting tested through these conventional labs do. Now, if Babesia is a paintbrush and Bartonella is a marker, clearly my red crayon is not going to tell you if you have a paintbrush or a marker either, right? Like you would have to order the test specific for Babesia or Bartonella. And there are a lot of issues with those tests through conventional labs as well. So if you look at a specialty lab like IGeneX, which is kind of the industry standard for testing for Lyme disease, they're going to be looking at all of the testable species. And then they also are going to be looking at various levels of antibody production or immune response. Because we can't forget that a lot of the testing, they're indirect. So they're looking at the immune's response to the organism. And there's a couple issues that can arise because of that. If you pull a tick out of you on Monday and you go to your doctor on Tuesday or Wednesday and get your blood drawn, maybe on Thursday, enough time is not elapsed where you're going to actually see antibody production in the level that's high enough for these conventional labs to pick it up. So a lot of times you're going to end up testing negative, and there you go, right from the get-go. Oh, you've been tested for Lyme. It definitely wasn't Lyme, and you go down this other crazy pathway of all of the other things that it could be, but it's definitely not Lyme. And then when you're working with a specialty lab, you do have to be careful because, you have to know how to read these tests. You can't just look at negative or positive. You have to know what the different numbers mean. You have to know what the different antibody production levels mean. And you have to be able to really look at your patient and say, okay, we've ruled all this other stuff out. Here's the clinical picture. Here's what they're presenting with. And then here is, kind of this laboratory evidence. And putting that all together, you make the clinical diagnosis, because all of these vector-borne diseases, Lyme disease is a clinical diagnosis. It's not a positive or negative on a test.
Do you think the testing is worthwhile? I've gone back and forth on this. I used to be more against it. Now I'm a little bit more actually for trying to at least identify one organism. And mainly it's because, as we discussed earlier, the treatment timeline can be longer than I think most people would like. And there can be, in some cases, fairly significant worsening of symptoms via the herxheimers. So knowing with at least a small measure of confidence that you've identified one organism, I think gives people some solace. Like, yeah, we're on the right track. It's not the wrong thing that we're treating, and that's why I'm feeling worse. It's because these organisms suppress the immune system, cause inflammation, so on and so forth. So I guess what I'm asking is, how do you think about testing from a compliance perspective? Do you find it to be helpful?
So I love to give people answers. and I love to have objective information. I love to have a baseline. So ideally, I love to have the tests, right? But they're expensive, and I have a lot of patients who just can't afford to do it. And so I will leave that up to the patient's discretion. But most of the time, I would say 9 out of 10 times, I have probably 9.5 out of 10 times, I have some sort of documented tick-borne infection. It might not be a blatantly, positive, but I see antibody production. It might be in an indeterminate level or something like that, but I see the antibody production that tells me their immune system has seen the various components of these organisms. Now, I am not someone who uses pharmaceutical antibiotics. So, if I were a practitioner using pharmaceutical antibiotics, and if you are a practitioner using pharmaceutical antibiotics, then I 100% think that you need to know what co infections are there. Because if your patient has Babesia, and you are not using antiparasitics to treat Babesia and you are just using antibiotics to treat Lyme, that patient is more likely than not ever going to get better because you're missing the Babesia, and the Babesia is keeping the patient from being able
Yeah.
to get the Lyme out.
And
Now,
this is what I think accounts for some of those cases that we probably both see who said, yeah, I did the whole Lyme thing with the Lyme doc, was on heavy doses of antibiotics for a year and a half, two, didn't feel better. And I think part of that is not the doctor's fault because, again, from my understanding, the Babesia testing, it's only getting suitably accurate over the past maybe 5 years. So part of that could have just been limitations in the diagnostic yield, if you will. Um, but yeah, this is one of the reasons why I think the testing can be important. Now, I guess like the devil's advocate there could be, well, is someone having problems with sleep, especially if they're waking up hot? Are they having air hunger, all like the classic Babesia signs, right? Do they feel tippy and off balance? Do they have a dry cough? So you can look at some of the symptoms to get some clues for, wow, there's kind of a predominance of Babesia symptoms. But even with that, there's a lot of overlap between the symptomatic presentation of these different organisms.
right. And I mean, as far as like when I'm treating, so again, like if I know one is there, if the patient, and even if I've tested, so even if I have a negative Babesia test, if I have someone having drenching night sweats and they have that distinct Babesia headache and they have anxiety and they are off balance and dizzy, I'm going to overlap my treatment for Babesia. And that's a lot easier for me to do, when I'm using herbs that have dual benefits than it is for, someone who's using pharmaceuticals to be like, okay, we're going to put you on tafenoquine, or we're going to put you on azithromycin and atovaquone. And then, by the way, we still have to have you on something, to treat the modal form of Lyme too, if we're simultaneously trying to treat both organisms. Um, so again, I'm going to treat based off of what you're clustering in as far as your symptoms. And for me, it's not adding an extra three things. It's being smarter with the herbs that I'm choosing.
Yep, yep. Richard Horowitz is pioneering this dapsone protocol for Lyme. He's gone so far as to say he thinks he might, and he's been cautious, but might have a cure, even though that's truly a four-letter word in a lot of circles of medicine. Do you find any cases that are really prolonged, recalcitrant, where you've referred for the dapsone, or you've heard people who've done well on this sort of fairly robust and maybe kind of hard to get through antibiotic protocol that might have some really significant upsides on the other side of the treatment course?
Yeah. So Dr. Horowitz is my co-host on the Healing Lyme Summit. I've learned a lot from him over the past more than a decade. And I have a lot of respect for him and I trust him. What I will tell you from what I see in clinical practice is that, the people who are in remission or who have had their infections resolved from using dapsone are not the patients that are showing up, on my doorstep for treatment, obviously, because they don't need me, right? They've found their route to a resolution. I have patients that have been on dapsone and have not found, the relief that they're looking for. But I have watched Dr. Horowitz's patient testimonials, and they are amazing and they're compelling. And I wholeheartedly believe, what he is sharing as far as his research and whatnot. But again, it's like I don't see the patient that was cured by dapsone. And that being said, for all of the other practitioners that might be listening to this, like I'm sure people have gotten my patients that I wasn't able to help, right? Just like I get a lot of patients from other practitioners. I think that this is such an individualized infection. It preys on our genetic weaknesses. It preys on our previous injuries. It preys on what is going on in that individual. And there are different methods and different approaches that are going to work for some people that aren't going to work for others. I mean, the biggest take home is like there is literally no one size fits all protocol when it comes to healing these infections.
Sure. Well, I appreciate the humility, because one of the things that we all see is confirmation bias, right? I see the patients that work well with my approach, and I don't see the failures. And I wish it was easier to do follow up of all your patients. And this is something that we're slowly working on. Being a small clinic with limited resources, there's a lot of things on our would like to do list that we're trying to work around too. But one of the things we want to try to track is how many people are we losing? They're not following up over time. And then will they answer some sort of short form as to why, just so we can have a better sense? Because I'd love to know what my true success rate is when not viewing it through the prism of the people who keep coming back, because that's obviously going to be really skewed with a confirmation bias built in. But I think also to your point, there's a lot of options out there for people. So, if we all keep an open mind and just keep working the problem, people will find their way to what they need. One of the things I'm also curious about, sort of in that vein, is SOT therapy. This is something I find to be quite interesting. I don't know if we would say it's natural or it's not natural. It's maybe in between the two. I'll let you define it if you like it, and then maybe if you want to give any thoughts you have on SOT.
So I'll be honest with you, it's not something that I'm well versed in at all. I interviewed Dr. Andrew Peterson last year for the Dr. Talk Summit, and it was really the most I had ever learned about it. Theoretically, it sounds legit. I've had patients who have failed it. I've had patients who have been helped tremendously by it. But it's almost like, you have to go through and do each like a round per organism in the body. You know what I mean? So again, it's not something where you're going to go on one protocol and it's going to tackle everything, right? But I think that it can be, again, for the right person, a significant piece of the puzzle. But it's not currently something that I do or that I have really any experience with. So I just want to be
Gotcha.
honest about that.
Yeah, no, again, I appreciate the honesty and the transparency. For the audience, SOT, it's a gene therapy that targets the messenger RNA of the microbe and actually prevents it from making proteins that the bacteria or the protozoa needs to survive. And so it dies. The case for testing is really made, I think, in part here, because you have to have a specific species to then make the mRNA target SOT4. And so this is where you want to order the test that's going to give you the highest probability of a positive so that you can do the SOT for a specific species of Babesia or Bartonella. And from what I've heard, some people will see a real response to one of the organisms that they've tested positive for, but maybe not to the other. I think it has a lot of attractiveness for someone who's not done well on other therapies, and they just seem to need another tool to bring down the load of infection so that their native immune system can get you the rest of the way there.
Yeah. And I think that's the big piece, and you brought up earlier, like if you stop treatment too early, right? Or if you don't treat to completion, And, that was a valid point that we really didn't discuss. But again, like this whole thing comes back to, and I'm going to diverge from SOT for a sec, but it's like there's no antibiotic that ever wipes out 100% of any bacteria from the body. Antibiotics stop replication. Basically, you think about it as it shrinks the load, but it doesn't shrink it to zero. It's the immune system that has to come back in and has to completely like obliterate that infection. So a lot of times, I will have patients that will become symptom free, and I will actually go back and look at all of the immune markers, the inflammatory markers. I'll go back and look at their antibody production and do the same test, that was positive in the beginning. I don't know how you feel about this, but I am personally looking to make sure that at least all IgMs are gone and that the IgGs have fallen into the realm of like a moderate or an intermediate, where theoretically you could think they're memory cells. If you still have sky high off the chart IgGs, that's not suggesting a resolved infection. And so sometimes it can be like, okay, yeah, you've shrunk that infectious load down to the point that they're symptom free, but you've not fully recovered the immune system. And so if that's our sense, then we keep going. Because if you don't fix the immune system, the likelihood of it coming out of hiding and starting to replicate and become active again is very, very high.
Now, can certain organisms, I might have some of my immunology off here, but doesn't Bartonella suppress production of IgG?
So that's the other thing. So I mean, so it's not just Bartonella. All of these affect the immune system, and not only do they affect the T cells, which we were talking about, but they affect the B cells, which are the cells that make antibodies. So this is why a lot of patients can be seronegative, right? They're not making antibodies that are detectable on a test. But also they can have very low levels of antibodies, again, which is why these specialty laboratories, that give you these intermediate levels are so valuable to treating and also to kind of having an idea of when the infection has resolved. In my experience, I've seen patients that were like borderline positive, I'll call it. And then once they go through treatment, because I have patients that are like, I just really want to know where I am. Can you reorder the test? And it's like, well, I guess if you don't mind paying for it, I'll reorder it. You reorder it at like 6 to 9 months. And even though they're feeling better, they're like, oh my God, you've made my Lyme worse. And it's like, whoa, 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 why do you think that? And it's like, because look, I'm positive now and I have all these pluses or all of these high numbers, whereas like before I didn't. And it's like, no, look at now your immune system has pitched in and it's fighting with us. You know what I mean? So I don't think that in the end of treatment, when symptoms have resolved and the patient is feeling much, much better and much more normal, that the absence of antibodies are because of immune suppression and the patient just being seronegative. I
Yeah,
think that that's
in that context
a
makes
true
complete sense.
resolution.
Totally. And so for our audience, we're talking here about assessing the immune system response via antibodies, but there's also directly identifying whether it's through PCR or digitally enhanced PCR or FISH, which is another way of looking at the genes of the bugs. So you're directly finding the organisms in the blood. Are you looking also, so to complement the antibodies, also looking at these direct measures as part of your testing assessment?
Yep. So if we're using IGeneX, I will use a FISH test for Babesia and Bartonella. There is no FISH test for Borrelia, which is the organism that causes Lyme. But they do offer PCRs. Now, I will tell you, I like rarely have seen a PCR positive patient. For whatever that's worth. So, if I'm ordering a panel and it comes with it, great. But it's not something that I honestly would ever ask a patient to spend extra money on because again, I rarely see PCR positive.
Sure. Shifting gears maybe for a second, are there a few common mistakes you see people make? I mean, we all make mistakes. We're all human. I think doctors and patients alike. But are there a few more common that you'd want to make people aware of? Maybe give them some preemptive advice regarding?
Sure. I would say whether you're using pharmaceuticals or using herbs, if you are focusing on killing these organisms alone, you're going to fail. This is not, it's, I'll just leave it at that. Number one. Number two, if you don't fix the gut, you're never going to be able to detox properly. And your chances of getting this organism out of the body is going to go down drastically. Number three, your microbiome is responsible for your immune system. Over 70% of our immune system function relies on our gut, and a big, big piece of that is our microbiome. If we have dysbiosis, meaning an imbalance between the good and the bad bacteria in the microbiome, you're not going to be able to manage inflammation. You're not going to be able to recover your immune system. So it just goes way, way, way beyond thinking of this as we must kill this infection. We have to start thinking about how do we heal this person, and specifically, how do we heal this person sitting in front of us?
Sure. Love it. Love it. And I'm going to take us a little bit off the beaten path here, but knowing that some people come in so sensitive gastrointestinally, it gets me thinking about this meta-analysis on hyperbaric oxygen therapy for Crohn's, and the either response or remission rate in this gastrointestinal autoimmune condition was remarkably high. And so it's something that we're toying more with at the clinic because, I mean, there's multiple benefits to hyperbaric, but in quelling some of that inflammation in the GI, if they're really immunoreactive, um, I see that as a potential prospect. Have you integrated it all into your care, or do you have any thoughts about hyperbaric?
I love hyperbarics. We have a Vitaris 320 by OxyHealth in our clinic. And it's a wonderful tool. You know, the thing with hyperbarics, I wish that patients could do it, throughout. The unfortunate reality is a lot of patients can't afford to do it for more than a month or two. And so I think the timing of it is really important because not only is it an anti-inflammatory, not only does it help you detox, not only can there be some killing effect from it, but it really helps with neuro regeneration. And so for me, I always kind of want to use it on the back 50% of treatment because, if you have all of this other massive inflammation and everything going on when you're using it, I feel like you're missing almost like that regenerative piece. So if a patient can only use it for a month or 2 months, I always kind of want to do it once I feel like we've gotten over the hump, if
Right.
that makes
I think
sense.
that's fair. And no, it makes complete sense. And also, I have not been able to get a straight answer on this, and there's just not research here, but Babesia being a oxygen loving organism,
Mhm.
there's concerns that hyperbaric might fuel Babesia. Now, what's interesting is that I believe it's tefenaquine is thought to work through a mechanism of killing Babesia by increasing oxidative stress, as does high dose vitamin C. So I'm still sort of debating, for Babesia, is that potentially going to flare it or might it help it? But I think, kind of in keeping with your timeline recommendation, waiting until someone's, somewhat quiescent, we're getting the symptoms down a bit, and probably doing the hyperbaric along with antimicrobial therapy just to be on the safe side seems to make sense. One data point I would add to this, it's the Fife study where he looked at about 90 patients with, now this is Lyme. This is a study from like the 1990s. So all they had positive was Borrelia. But knowing how common Babesia is as a co-infection, I think we can say about 30% of the people in that study were probably also co-infected with Babesia. And he reported like an 80% response rate when using hyperbaric with antibiotics and virtually no adverse events. So it makes me think that, we would have seen more of an adverse event profile in the Fife study if we were actively feeding Babesia.
Right.
Um,
And I
what do you
think the
think?
other thing too is like a lot of the symptoms of Babesia is because of the way that Babesia infects the red blood cell as well as the endothelial cells. And so, you know, if you look at it as some of the symptoms, right? Maybe like the shortness of breath, the chest pain, the cough, even some of the tipsiness and the dizziness, right? It's like how much of that is because of like the dysfunctioning of the red blood cell and its ability to carry oxygen, right? So if we're hyper oxygenating the body, you know what I mean? Is it helping with a lot of the symptoms of babesia? Because it's now you're delivering that oxygen that the cells were so deprived of because of the mechanism of action of babesia.
Certainly. And I mean, just personally, from a cognitive perspective, when I do dives, it just feels like my brain is turned up, maybe 10%, 20%.
Yeah.
Cool. Any other therapies that we didn't, I mean, there's probably a lot, but any that are sort of worth mention that we haven't hit?
Well, I love red light. I love far infrared sauna. I love so there's a device called Brain Tap. I'm sure you've heard of that.
Yeah.
Yeah.
I haven't been using it for a while, but I'm glad you mentioned it. So is this for autonomic dysfunction sort of presentation type?
Yeah. Yeah. So
That's great.
it also has some binaural beats. It has the red light therapy. So I think it's wonderful. Yes, I would say predominantly for balancing the nervous system. What else do we do? HBOT, like I recommend doing, nutrient rich IVs if a patient can afford to do that. Um, and then I do a lot of lifestyle medicine, getting back to the basics, like the basics of making sure that you're sleeping well, making sure that your diet is working for you and not against you. You kind of brought up like, what about these really sick patients that can't handle much? Well, a lot of times it's like, okay, so start by taking the things away. Take out the gluten, take out the dairy, take out the sugar, take out the foods that their immune system is reacting to and mounting an inflammatory cascade against, right? So, not to deprive, but there's a lot of things that we can do through omission. Getting people outside, laying on the earth, as long as there's no ticks there, um, being out in the sunshine, being out in fresh air, laughing, like all of these other things that are free, right? That people don't have to pay money to do.
I'm assuming you see food tolerance increase through the course of treatment for a
Yeah.
vector-borne infection. Yeah. So I'll just flag that for our audience because it's another suspicion that I have is that the inability to regain food tolerance, there may be a non-gut driver of that.
Mhm. Yeah. I mean, I would say red flags, for people that don't know if they have Lyme, but maybe suspect it. If you're ever diagnosed with an atypical diagnosis, huge red flag. Huge, huge, huge red flag. If you are not responding to medications or
And sorry,
treatments.
will you define atypical for our audience
Oh,
and like
sure.
just, translate? Yeah.
Um, so like when you have a diagnosis, right, you're supposed to have a list of symptoms and a list of laboratory findings. And, let's just use MS for an example, right? And then you would have a list of imaging findings like in your brain, cervical spine, thoracic spine, et cetera. Like you would expect to see certain things. So I have a lot of patients that come to me that have been diagnosed with atypical MS. And so what does that mean? Oh, I have all the symptoms of MS, but my blood work doesn't suggest I have MS. And, my scans are not showing what you would typically see in MS. And it's like, okay, then keep going. We have diagnostic criteria as physicians for a reason. Okay. So if you don't fit that diagnostic criteria, keep searching because that's probably not what you have. And by the way, if it doesn't resonate with you, if you're like, yeah, that's not me, it's not you, keep going. But the second is if your body doesn't respond to medications the way you're supposed to respond, right? So, like, for example, anxiety caused by tick-borne disease is because your brain's on fire. It's not because you have a neurotransmitter imbalance. I mean, eventually Lyme and Babesia and Bartonella can cause neurotransmitter imbalances, but that's not why it's happening. It's the inflammation or sometimes an autoimmune process, like with a lot of pediatrics where they have PANS and PANDAS, which we could talk about for hours. So I would say not responding to medication, atypical diagnosis, if your body doesn't heal right. And this could be something as little as I went for a walk and I feel like I ran a marathon. Or, I worked out lately in the gym and I feel like, I lifted the heaviest weights of my life. Or, I had surgery and my doctor says I'm not healing the way they would expect me to heal. Or I keep getting all of these cuts and scrapes and, or I keep getting tendonitis. Those are all signs that your immune system is not functioning properly, catching every cold, right? All of these sorts of things. And I think another key is you feel like your whole body is imploding at once. Like, okay, I have all these mental, emotional, cognitive things, and I have like these weird urinary things, and I have like heart palpitations, and like my knee hurts. And it's like, it's not likely that your body decided to self implode all at once. It's likely that you have an infection in every cell of your body. And that's what's causing this multi-system disaster and symptoms to come out. And one other one I want to bring up is like, things just happening overnight. You were fine and then all of a sudden you weren't. Like that's an infectious process. That is not neurodegeneration. That is
Mm,
not, that's not normal psychiatric disease development. So if you feel like you were fine one month and the next month you weren't, it's more likely that it's an infectious process.
well said. That is how Tania Dempsey described it to me. She said people just fall off a cliff,
Yeah.
essentially.
Yep. And also, if
Well,
you've been
Myriah.
from doctor to doctor and they tell you that you're crazy, chances are.
Yeah, fair enough. Fair enough. Myriah, I feel like we could talk for another 3 hours. Where are you hanging out? Where can people find more about you?
Okay, well, so my medical practice is in Connecticut. It's in Hebron. So that's called Tau Vitality, TAOVITALITY.com is our website. And I'm hosting the Dr. Talks Healing Lyme 2.0 Summit again in 2025. So that airs the week of April 15th. It's free. So, we have over 40 industry experts. Dr. Horowitz is my co host. So you can find me there. I speak at medical conferences around the country. So the International Lyme and Associated Diseases Society.org or ILADS.org is a wealth of information that people should check out. They can help you find a practitioner. I'm a fellow of the Medical Academy of Pediatric Special Needs. The website is medmaps.org. They have a wealth of information for the pediatric population. I'm starting a podcast this spring called
Sweet.
Lyme Bites. So
Nice. Great
LYMEBYTES,
name.
right? I thought it was fun. Gosh, I think that's it for now.
Well, it sounds like you're staying busy enough.
Yeah.
Boy. Well, cool. Well, again, thank you so much. I appreciate you, the work that you're doing, and I'm sure it's helped a lot of people today.
Thank you. I really appreciate you. It's nice to meet you. And thank you so much for having me on your show.